Good morning. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. Today, we are discussing progression. And as we all know, that is a topic that is foremost on most patients and caregivers and all people in the MPN community. That is on their minds constantly. We hear from all of you pretty regularly, and that is even from new patients that are fearful of what's to come. With me today are our lovely partners. I love the MPN Research Foundation. I was there for almost 9 years, and it is now in the hands of a very capable, wonderful woman, Kapila Vegas. And she is with us today, and she's going to speak to you for a few moments. And also with us is our friend and colleague, Dr. Raajit Rampal, who you've seen before on many of our programs. He works with us on the veterans, the issues with Vietnam vets and their exposure to Agent Orange. He's been a real steward and helpful to us in that area as well. Raajit is coming to us from Memorial Sloan Kettering. Please, if you have questions, we will save time toward the end of this hour for your questions. There is a Q&A icon at the bottom of your screen. You can put your questions there. We also have a list that you've already sent us, and we hope to get to all of those today as well. At this time, I'm going to butt out and let Kapila take over from the MPN Research Foundation, and she'll explain more about their program and progression. Kapila.
Thank you, Anne. And good morning to the entire group that has joined us today. We really appreciate your attention. And Anne, thank you for the opportunity to connect with this broad community. As Anne said, my name is Kapila Vegas, and I lead the MPN Research Foundation. And many of you know us, but some of you may not. Just to reiterate our role in the broader MPN community, our mission is really centered around advancing the research into ET, PV, and MF. And we are pretty singularly focused in pursuing new therapies and better outcomes for all MPN patients. And so our role really is to raise funds and partner with all the stakeholders within the MPN community to invest in new frontiers, like the slowing or preventing of MPN disease progression. And so it's a topic that is top of mind for many of us, as it is for many of you. And we're very fortunate to have Dr. Raajit Rampal, as Anne said, many of you know him, a hematological oncologist at Memorial Sloan Kettering. He's been serving as our scientific and medical advisor to the foundation for a couple of years now. And as the topic of progression has started to bubble to the surface over the last few years as an area of focus and something we at the foundation want to take on, we have deepened our engagement with Dr. Rampal to lead us through this effort and deepen his scientific and medical guidance as the lead for our progression initiatives. And as many of you know, too, disease progression has been a topic that the foundation has also been exploring for quite some time. We started to recognize that it's not as easy as us funding a few studies in the lab. And so we've come to a point where we're looking at a much broader and robust approach to the study of MPN disease progression from many different angles. Taking more of a networked approach than a traditional linear or point-to-point investigational approach. And so maybe a little bit later today, as we take some Q&A, we'll get into more detail about what our approach to the progression initiative is and our overall research network. But before we get into those approaches, I really want to hand it off to Dr. Rampal. He's going to start us off with a discussion about what we know and maybe don't know yet about MPN disease progression and share his perspectives on the landscape for MPN disease progression. So with that, I'm going to hand it off to Dr. Rampal and look forward to the robust discussion at the end of this session. Thank you.
Thank you, Kapila, and thank you, Anne. And it's good to be with everyone. Let me bring up a slide. And this is going to be the only slide I show because I think that encompasses everything. So we could just show this slide. Hopefully you can all see this. So I just want to kind of backtrack and just talk in general terms, right, about what are we even talking about here? What are we talking about when we talk about progression? Progression means a lot of different things. And if we think about the landscape of what happens with somebody with MPNs, people come into this with different things. Some people have ET or PV, some people start with MF, but either way, right, if you think about somebody with ET or PV, or even pre-fibrotic myelofibrosis, we think about vascular problems, about clotting, and people can do well and be fine for a decade or more, but some proportion of people are going to progress into myelofibrosis, or again, start with myelofibrosis. And that progression is one of the key things we worry about and think about. And that's one of the things patients worry about, right? When patients are diagnosed with ET and PV, one of the most common conversations I have with somebody is the conversation of what's going to happen to me and when is it going to happen? And to be honest, I don't have any answers as to those questions. Nobody does. And within myelofibrosis itself, a lot of things can happen or nothing can happen, right? There are a fair number of patients who will have a diagnosis in myelofibrosis, and it will ultimately not impact their life or their lifespan, but there are a proportion of patients who the opposite is true, and it will shorten their lifespan, or it will cause them significant symptoms or other issues, right? And the things we always think about and worry about are that people can develop symptoms, they can develop the enlarged spleen and the liver, their blood counts can get low, and ultimately they can transform into leukemia. Now, in the current state of things, right, we have a number of new drugs and a number of trials going on for patients with ET and PV, for patients with myelofibrosis, for patients with leukemic transformation of MPNs. And it's great that we have all of these studies and there's all of this investigation going on. But if we take a step back and think about what's the ideal state, right? Where do we really, really want ourselves to be? And here we have to allow ourselves to dream and think big. We don't want people to progress. We don't want to be worrying about leukemic transformation. We don't want to be worrying about people having progressive blood count reductions or symptoms. We don't want to ever get to these points, right? It's the way we thought about this disease is very different than the way that we think about solid tumors. If somebody, for example, gets diagnosed with breast cancer, we don't say, well, let's wait till it's stage 3 or 4 and then we're going to intervene. We deal with it, we cure it, right? And that has to be our ambition, and our hope is to say, if somebody's diagnosed with a disease, we can intervene and we can halt it. Or, we may not, ideally, of course, we'd love to be able to cure the disease, but a functional cure to me means that we have somebody with a diagnosis and we halt it, and we halt the progression, and they have it, and it becomes a chronic issue like high blood pressure or something else, or like CML, which is another, which is in the family of MPNs, and that is dealt with highly effectively with medications, and it is rare for people to ever progress with CML these days, given the medications that we have. That's the ideal state. Now, why haven't we gotten there? Why aren't we there, right? Well, there's really two factors. One has been that we haven't had a lot of medications to deal with these diseases. If you think about it, really in the last 10 years, we have Hydrea, we have Inegrelide, we have interferon, we have ruxolitinib. That's not a huge armamentarium to deal with any of these diseases. The landscape is changing, and that's an important thing to realize, right? There are so many drugs in investigation now for MPNs, I think at this point, more than I've ever seen, for MPNs. And so that is a reason to be optimistic, right? And these drugs are, for the most part, being studied in people with more advanced myelofibrosis, but if they work, if they're active, that brings the opportunity to think about bringing those drugs earlier on in the disease and maybe halting the progression. So I think from a high level, we are getting access to more tools that we need to intervene. But the second part of the problem here is maybe the most important part of the problem, which is that if you think about, patients as a group, as I mentioned earlier, some people are going to do fine, and some people are going to have a more difficult and involved course. And it's really, and it's essential that we try to figure out who are those patients in those groups, because when we think about intervening, we want to intervene with medications or other modalities in people who are actually at high risk. The first principle in medicine is do no harm. And by giving people drugs indiscriminately, there's absolutely the opportunity to incur clinical toxicity and financial toxicity, right? We never really think closely about the costs that come out of, or the dollars that come out of a patient's pocket when we write a prescription. And so we have to be judicious about saying, well, we should put everybody on X, Y, or Z regimen. And that's where the work in the Progression Project really comes in, which is really trying to understand who are those patients who walk in the door who we know are going to have a problem in the next 5 years. That's the first question. And the second question is, what do we do about it, and how do we do something about it? And we're really going to learn two things, I hope, in all of this work. One is, again, how do we take two PV patients and say, well, this patient is going to have a tough course and this patient's going to be fine in all likelihood, number one. And number two, why are they different? And number three, what tools do we use to try to prevent that patient who is at higher risk from progressing? So to me, that's kind of the landscape of what we're dealing with here. But I hope you will all agree that this is really of the utmost importance, because we have made tremendous progress. There's no question about it, but we want to move into a more ideal world in MPNs. So Kapila, I will turn it back over to you.
Great. Thank you for that, Dr. Rampal. Appreciate the overview and the landscape. I know many of you out there have lots of questions, and we want to get to them relatively quickly. And I also wanted to share that from our team, we have Rick Winokur joining us, who is really our lead for our scientific strategies and programs to help us with some of that. Before we jump into that, though, I did want to share a little bit about how we at the foundation are looking at our robust approaches to progression. Let me share one quick slide just to level set where we're headed, and then we can jump into a conversation. One sec. There we go. Hopefully that is now visible. So, as we've mentioned, and all of you know well, the area of progression has really been a longstanding area of concern, obviously with patients and certainly with clinicians, as Dr. Rampal has laid out for us. And so we've kind of started to develop this vision of a global network of researchers and clinicians starting to collaborate on how best we might study this for the prevention and treatment of disease. And what we're starting to build a strategy around is understanding really how do we better define what we mean by progression and get some actionable criteria around that. We want to also further develop predictive indicators of what might indicate that somebody might progress or not, and then build that body of evidence so that we can validate that and bring that to bear both with therapeutic discovery and development, but also, as it comes time to get therapies approved, we want to have that body of evidence as validated. That also leads us into trying to identify and define new clinical endpoints, whether they're the primary endpoints in traditional clinical trials or sometimes secondary or surrogate endpoints. We want those to be recognized and tested and validated as the research community and the therapeutic development community comes together to build those clinical trials for new therapies. And overall, again, underscoring what Dr. Rampal has said, how do we influence and develop new care guidelines across the MPN community? And so we're taking, as I mentioned, sort of a multifaceted approach to this, because it's really not as simple as funding a few studies, as we've said. We want to really be robust and comprehensive. And so we're convening the clinical community, the research community, patients, patient advocates, and we've come together now. This year will be our third year of convening a summit around just the topic of progression to try to understand where the landscape is and potentially where it's headed. We have, and probably will continue to do so, fund studies with individual investigators or collaborating investigators to start to uncover certain areas or directions around understanding progression. But more interestingly, I think that will kind of bring a lot of the pieces of this together is the consideration we have of building some type of observational database to build the evidence, the real world evidence with patient level data, research data, and being able to do this at scale so that we can start to find signals and different indications of what might help us uncover these 4 objectives that we have for progression. So just wanted to share with the community that we are spending a lot of time and energy trying to help solve this with our clinical community. And there'll be more to come throughout the year of how we progress, but we're excited about it and glad to be able to share that we are partnering up with Dr. Rampal and the broader community to build this broader initiative. So with that, Anne, I'll hand it back to you and we can kick off the discussion.
Okay, and you know, I like what Raajit said about the cost and about, wouldn't it be wonderful if we could predict when someone walks through the door and says, I've just been diagnosed with ETMF or PV, that within, you know, this is how we're going to treat you now. This is what you may have to be treated with in 5 years. But can you kind of expound on that a little bit, Raajit? If you don't mind, you know, a few people have emailed me and said, you know, how would one ever know?
I think that's exactly what we've got to figure out, right? And that's part of the goal of the project. I think that, is it an answerable question? I think it is an answerable question, right? And do we do this to some extent already? We do, right? And, you know, when we think about people with myelofibrosis, based on the understanding of the genomics, we've begun to be able to segregate people and say, look, these people are at the higher risk of progression and these people are on a lower risk. The problem with that is that it's a relative thing, right? It's not an absolute thing. It's not a predictive tool. We say the relative risk, somebody has a higher versus a lower chance of progressing, but that doesn't tell us if they will progress. And it's a hard thing to know that, right? Are we going to be able to get to a point where we can really completely predict who's going to progress? I think that's a really difficult thing, but can we refine the data so that we have a much more nuanced understanding and can say with more certainty that, look, if you're in the higher risk group, this is what it means. And once you know that, then we can start to think about how do you design studies to say, let's, you know, if we think that someone is a higher risk group, or if we take the patients in a higher risk group, and we try an intervention, can we prevent them from progressing, right? That's where we have to get to, but these are huge questions.
They are, and you know, one of the things that comes to mind is the patient that is not symptomatic, is not given a treatment and told to just live their lives, and when the time comes, if something changes. And then this just happened to a patient after 12 years with MF, no drugs, but was seeing his hematologist regularly, converted to acute myeloid leukemia. So, you know, and we've always said it is such a heterogeneous disease, and there are no guarantees. And I mean, it's and that also leads into the psychosocial issues of fear of what's to come. And you know, we're dealing a lot with those issues these days. And so do we know what percentage of MPN patients progress to leukemia at this point? Are there any statistics? I looked, I couldn't find much.
I mean, yeah, it's you know, roughly speaking, 20% of MF patients will progress to leukemia, and you know, maybe 7 to 10% of PV patients, and maybe 2% of ET patients. You know, but I think the thing is, when I have this conversation with patients, the thing I always tell them is, statistics apply to populations, not individuals, right? And so if I sit with somebody and say, with all comers, there's a 20% chance of an MF patient developing leukemia. I don't think it's such a meaningful thing to say to somebody, because it sort of depends on, well, which group are you? Are you in that 20% group that's going to progress, or are you in the 80% group that's not? And right now I can't say to somebody which group they fall into. So we have statistics, broad statistics, but I think what we want to hopefully do is start to bring this down to the individual level.
Right, which is pretty much how we do it now anyway, right? So in terms of signs of progression, so and Rick, if you were to
happy to join in.
Yeah, and Rick Winokur has been a colleague of all of ours, but with the MPN Research Foundation for quite a few years, and was with the Lymphoma and Leukemia Society for quite a while, correct?
Yes.
And so we're happy he's here with us today. But Raajit, one of the questions we got, and of course, this is again on the minds of all of our patients, but what are the signs of progression? And is it based on symptomology or bone marrow and blood tests? And by the way, we always have quite a few new patients with us at each of these programs. So, they don't know anything and except what we've been able to give them in the foundation and other organizations, but they've not heard from a hematologist that's an MPN's expert.
Right, and so there's two parts of an answer to this. One is that, what do we monitor for? Well, it's complicated, but we look for changes in the blood counts. We look for changes in the patient's symptoms. So what are the symptoms, right? We think about whether or not people start to have drenching night sweats, whether they're losing weight unexpectedly, or if they just don't feel well, or if they're more fatigued than usual. And fatigue is the most common complaint, but fatigue it's a very subtle thing, because when people say I'm tired, my first question to them is, what do you mean? Fatigue means different things. For some people, that means I can't get out of bed. For other people, it means I can't do what I want to do. And for other people, it means I can't climb a flight of stairs. And when it's the latter, that may be more related to things like anemia. But if it's the first two things, sometimes it's actually just related to the disease. But spending the time to kind of tease out what people mean when they say they have a certain symptom is absolutely important. And sometimes when someone has a chronic disease, they become accustomed to their symptoms, and it's not until you kind of really question what's going on, or you have a family member there who's been watching and seeing what happens, that you really understand that someone's having the symptom changes. So that's an important part of this. But it's really looking at the blood counts and looking at the symptoms that tell us that there's evidence of progression. Now, the second part of this is, are we doing this the right way? Are we actually assessing for progression how we should? And one of the things that I think is important are the fundamentals, which are that patients need to be plugged in with a hematologist who understands the disease and who is following them on a routine basis. Because one of the dangers that can happen is somebody, as you're pointing out, somebody's doing fine. And then the expectation becomes, well, if they're doing fine, they're going to continue to do fine, which may or may not be true. And sometimes they don't get the same amount of careful attention, right? They aren't, maybe the visits aren't every 3 months, they become once a year. And when we start to get comfortable with somebody having stable disease, that may not be the best thing. I think patients have to be monitored carefully. But the thing that I think we have to think about that should potentially change is how we monitor. There is increasing evidence, and this work a lot of this comes from Jean-Jacques Kalajian's group in France, that if we look at the genetics over time, there's evolution, and when there's evolution, that may be a harbinger that the disease is going to progress. He has very nice data showing this. Right now, in most places, I think, at least in academic centers, we get genomics on people. In the community, a little bit less extensive, but I think most physicians are doing it. But now the question is, should we be doing this every year? Should we be checking somebody's genomics every year? I think there's evidence to support that idea, and certainly the MPN there's an MPN initiative, through the MPN Research Consortium that is actually collecting samples for patients on a yearly basis and doing genetics and looking at how people do. And so that's going to give us some hint. But I think it might be a reasonable thing to start to entertain the notion that maybe we should be checking genomics on everybody. Now, whether or not insurance will pay for that is a separate question. But
right. And so, this begs the question. We are now seeing a larger population of young people being diagnosed with an MPN. And, we have a program for pediatric and young adult patients. And the question is, what do we do about children that are, we have a mom of an infant, we have a mother of an 8-year-old, so what do we say to them, in terms of what they can look forward to with their children and what's going to happen?
It's an incredibly complicated thing. So the textbook says that, well, people with MPNs are people in their 60s. I don't think the disease read the textbooks, because I have a very large cohort of patients who are under the age of 30. They shouldn't have MPNs. And of course, as you know, and I hope most of the community knows, my good friend and colleague, Nicole Cushing, who's across the street at Cornell, this is her whole focus is pediatric MPN. Now, the fact that we have that she has, created sort of a subspecialty of pediatric MPN tells you this is a real issue. This is a real problem. And I think, to your point, we have to think about those young patients very differently than somebody who's 70 years old who's newly diagnosed, right? There is a reasonable possibility that somebody who's diagnosed at age 70 will ultimately, to put it in real terms, succumb to other things, right? To heart disease or whatever it is. It may not, the MPN may not be the major issue in their life. But I think that it's hard to make that argument for somebody who's diagnosed in their teens, because I think it is likely that it's going to have some impact in their life if we assume that they're going to live 60 or 70 years. I think that we need to focus a little bit more and gather more data, which I know Nicole is really driving, and of course you are as well, to having the patients come together. We need more data, but I think in principle, how we approach the younger patients needs to be different in all likelihood.
And so, and Dr. Razar, Linda Razar at Johns Hopkins is also a partner with us, on the subject, but so we know that there are a lot more treatments, more treatments, I won't say a lot more, that are approved by the FDA for MPNs, but there are many more in clinical trials. And so can you speak to the drugs that are currently available to our patients that are possibly inhibiting progression or having some effect on progression?
Yeah, that's a great question, because there is some evidence here, right? And now it's not, I will say with the caveat, it's not as yet robust, but there's two recent observations that I think are important. One is that there's a trial that was done by Dr. Barbuy and friends in Italy, and they started treating younger patients with polycythemia vera with Ropeg interferon, which is now approved in the United States. And interestingly enough, they identified that there was actually less incidence of clotting and to some degree progression in young people who got the Ropeg interferon versus those who were just treated with phlebotomy. Right now, our standard of care for young people is just to phlebotomize them and give them aspirin, and not to give them interferon unless they have a clot or if they have symptoms. But that was a striking piece of data. That is the first prospective data that I'm aware of that said, wait a minute, maybe we're not doing the right thing. Maybe if we take these patients who we've traditionally said we're going to just phlebotomize and treat them earlier, maybe they won't progress as much. Now, it was a very small study. It was only 100 patients or so. The study was actually stopped by the safety monitoring board because of this finding, because they said, well, look, the patients who are in the treatment group are doing better. But I think, to me, that's such a fundamental observation, and that's got to be expanded on, because if that's true, if that can be shown in a larger population of patients, that should completely change how we treat patients with PV. The second point along the same lines is that there was a nice paper from our colleagues at Cornell that Dr. Silver, Dr. Scandura, and the entire group at Cornell was involved with, where they retrospectively looked back at their PV patients who were treated with phlebotomy or hydrea or interferon. And what they observed in a retrospective manner was that patients who were treated with interferon had a lower chance progression to AML and to myelofibrosis. Now, we have to be careful because that's retrospective data, and they were looking, I think, at the past 40 years. It's not prospective data, but I think it's a really interesting signal that maybe the interferons do play a substantial role in potentially halting the progression. These all need to be validated.
Yes, which is fabulous, because we do know some patients that were given, that were treated with interferon when they were diagnosed at an early age. A few of them were in remission just off the top of my head, they were in remission for quite a while. Now we do know one for sure that, did have a horrible reoccurrence after having a child. But despite that, I do think this evidence that has come from those papers, it was excellent. Now, one of the questions is,
Anne, can I just jump in for a second? I just think that the conversation so far, and especially with respect to what Dr. Rampal said just recently, it really speaks to the fact as to why this large observational real-world evidence database is needed, because we continue to talk about smaller studies, that either need larger patient numbers or that need actual endpoints that are recognized by the regulatory authorities as being meaningful. So there's a lot of these endpoints that we all believe are important, but we haven't really truly demonstrated it yet. So I think that's what we're trying to close that gap, so that we have large numbers, because as you said, this is a very heterogeneous disease, and we need large numbers to capture the natural history of a heterogeneous patient population. And then having these recognizable endpoints, I think, will enable those doing the trials to be able to actually answer the questions prospectively and definitively. But we got to fill that gap first.
Right. And Dr. Rampal, you talked a little bit earlier about what a hematologist looks at, what the physician looks at when being able to predict changes in progression. And is it biological? This person is asking, what are the factors that influence that?
Love that. It's another great question, but it's. I'm not sure that we know, right? I think that it is. Is it the genetics? Sure, it is. And what's the evidence for that? Well, people acquire mutations, and observational studies suggest that their disease trajectory changes. And taking those ideas back to the lab, we know that when we start adding mutations in mice to JAK2 mutations, the disease evolves, right? So that's, to me, the clinical and the biological proof that these mutations play a role in the disease evolving. Now, how did they get there? Why are they evolving? That's a tough question, and that I'm not sure we have a really good answer to. So that's part of it. There's also now increasing thought about inflammation playing a role in causing the disease to progress. But again, it's at the stage of chicken and egg, right? What causes the inflammation? Does the MPN cause the inflammation and results in sort of a self-perpetuation of disease? That's certainly one element of the thought here, but it's an incredibly complex biology that is being investigated from a number of different angles.
So you're going to love this question, because I've been in this space for 17 years, and I will tell you that in the very beginning, when we would host these events, and people would say, well, what about the allele burden? And it would just be passed over and ignored. And, there were lots of our KOLs that said, oh, don't think about that. It's really not significant. So now you can answer this question, because we know that thought has changed. How does the allele burden play a role in progression, do you think?
It correlates with in general with the severity of disease, meaning that if we think about patients with ET, they tend to have a lower allele burden than people with PV, and as PV progresses to myelofibrosis, the allele burden increases. Why is that happening, or how do we reconcile that? Part of it is probably because if we think about the blood production as a jar of marbles. Let's just pretend we have a jar of marbles. All of them are different colors because how we make cells is fairly heterogeneous. And then we think about a red marble that gets in there, which is a JAK2 marble. What we think happens over time, or what the allele burden reflects, is that in that jar of 100 marbles, the number of red marbles starts to proliferate and kind of take over production of blood in the bone marrow. And so what the allele burden is reflecting is probably the amount of disease that's in the bone marrow, or the amount of mutated cells that are giving rise to blood. So that's the importance of it. I think that's how we think about it, that it's sort of expanding its representation in the bone marrow, right? So that's why we think there is a correlation with the disease progressing. Now, that's the theoretical framework. What does it mean practically? So somebody gets their JAK2 mutation testing and it's 15%. And so 2 years later, their physician does it again and it's 20% or 22%. Does that mean they've progressed, right? That's the practical question. That's the hard question, because it's hard. It's by itself, I don't think it's enough to say that there's been progression in the context of other things, right? Let's say that the blood counts have gotten worse, so there's worse symptoms. Yes, it has to be put into the right context, but in the current state, it's hard to say that just because an allele burden has increased, that the disease has progressed. There is probably some degree of truth to that, but I don't think we have enough robust data to call it a progression event yet.
So I know you're very familiar with the Calor mutation, and so I know you've discussed this before, and others, that if you have the Calor mutation, chances are you may not be as symptomatic, or you may have a better go of it with an MPN. Can you explain that?
Yeah, I mean, there's been a fair amount of data that has said that Calor mutations, and there's essentially two types of Calor mutation, type 1 and type 2, that people with type 1 Calor mutations may, relatively speaking, do better, right? And so in the context of ET, that finding of the Calor mutation has changed everything, because we used to put people into two buckets for risk of clotting, high risk and low risk. And now that has been changed to 4 categories of very low risk, intermediate risk, and high risk. And it depends on whether or not you have the calreticulin mutation. But the clinical implication is that we treat people differently. So if you're high risk, you need to be on therapy. If you're intermediate risk, you really may not need to be. And if you're low or very low, you may not need to be, you shouldn't be on therapy. So that's where the Calor has had a practical impact on how we treat patients with ET. In myelofibrosis, it seems that having that type 1 Calor mutation is associated with a lesser risk of progression. But again, we come back to this whole point about relativity, because I have seen plenty of Calor mutant, AML arising from MPN. Why did that happen? How did that happen? It depends on the rest of the context, and that's really what we've got to try to understand. Is Calor is one variable, but there's many other variables. What are they, and how do they impact that Calor? But again, relatively speaking, Calor mutations are associated with lesser chance of an event happening.
And so, speaking about mutations, because when I started in this field, it was there was one that we really talked about, and that was the JAK2 gene mutation, which launched much of what's happening today, basically. So we know MIPL and many others. Is there any significance in the other mutations that have directed you to, or have influenced how the patient responds, to an MPN?
Yeah, it's a good question. So there's a couple of things. One is that other mutations matter. So some mutations are clearly associated with the disease progressing. We know that, and now we've known that really since 2013 or so. So it does have implications for whether or not somebody may progress. Number two, does it have implications in terms of someone's chance of responding to therapy? It does look like the answer is yes. So, people who are treated with ruxolitinib for myelofibrosis, if they have 3 or more mutations, their odds of the treatment not working in the short term increase. And if they have specific mutations, their odds of the treatment not working in the near term increase. So the mutations do matter in terms of causing the disease to progress, but also in terms of their response to therapy. I will add in the same vein, though, some of these other mutations are an opportunity because some of them are actually targetable. And there is a mutation called IDH2, which happens in leukemia, but also in patients with MPNs. We've known now for a number of years that patients who have an IDH2 mutation are at higher risk of their disease progressing to leukemia. But as it turns out, there is an FDA-approved drug that targets the IDH2 mutation. And so there is actually now a early phase clinical trial from the MPN Research Consortium that is actually using both the JAK inhibitor and an IDH2 inhibitor to target these patients who are at really high risk of progression. This is the first molecularly driven trial in MPNs that I'm aware of. And that, I hope, is sort of our blueprint for how we do things in the future.
So Dr. Jameson, Katrina Jameson, and I try to read all of your papers and as much as possible and learn from those and see what everybody's up to. But removing the source of why a person gets an MPN, what are your thoughts just from your years of experience and the work that you do on a daily basis? We say it's an acquired blood cancer. Can you speak to that a little bit, Raajit?
Yeah, I mean, it's having a mutation doesn't mean you have an MPN, right? So that's the first observation. And so there is something called clonal hematopoiesis, which is a condition where somebody has a mutation, but they don't actually have a hematologic disorder or malignancy. It affects probably 10% of the population. It's associated with an increased risk of people developing a blood cancer. But one of the most common mutations in clonal hematopoiesis is JAK2. So there are a group of people walking around who have a JAK2 mutation and have no evidence of an MPN. They just have the mutation. Which what do we take away from that? What does that mean? It means that there are other things that probably need to co-occur aside from just the mutation, potentially, to cause a disease to happen. Could you potentially figure that out and figure out how to sort of disengage the JAK2 mutation from its partner events that are causing the disease? Maybe, and I think that is certainly something people are thinking about, and I think it is a really reasonable hypothesis to pursue. So could you eliminate, as you said, the source of the MPN? Yes, maybe we could, and I think that should be the goal, right? And so one approach would be to, again, take away the collaborating events that occur with JAK2. The other thought, in the era of CRISPR is, could you just edit out the JAK2 gene, right? And we're certainly not there at all at this point. It's theoretical in terms of how you would apply that clinically. But yeah, I think, is that something that could be of interest in the future? Yeah, or even figuring out how to better selectively target JAK2 mutant or MPN cells that drive the disease. Yeah, I think that really has to be, that's kind of the fundamental goal, right? And that's going to take quite a bit of work, but there's a lot of people working on it.
So we have so many questions, so just bear with me. So would you say, so when do you decide, this is about stem cell transplants or transplants, as a patient starts to progress, when do you have that discussion with them?
This is one of the most challenging questions there is, and there isn't, the principles here are always, you don't want to go too early and you don't want to go too late. And that sounds really nice, but in practice, what does that mean? And the reason is really that roughly speaking, the stem cell transplant comes with a 20% risk of mortality. That's a big chance to take, and it has to be justified. And that's why we don't do it early on in someone's disease if they're doing well and they don't show signs of progression. But at a certain point, if the treatments are not working, or we're starting to see that the treatment is starting to fail, that's clearly a time to move on to the transplant. The difficult situation, which is the situation for many patients, is that they have some high-risk mutations, but they're on ruxolitinib or fedratinib, and they're doing well, and they're living a comfortable life, and they feel much better than they did before they started treatment. When is the right time for that patient to take that risk, right? That is a very, very difficult question. And I don't think anybody has a clear answer to that. We're certainly trying to get a better answer to that. And that's actually some of the work we're doing with the foundation in collaboration, is trying to collect data from as many centers around the US and Canada on terms of how their transplant patients have done. And can we learn some of the factors that say to us, wait a minute, someone's risk of transplant might be very, very high, or it's not likely to work, versus somebody else who it's going to work really well for. If we can understand that, we can better decide who is maybe the right patient to go earlier or not. But it is a really challenging question.
So the question is, where is the MPN starting? Is it the bone marrow? Is it stem cells? I mean, can you explain that, please?
I mean, we're learning more about this. There have been 2 papers in the last year that have shown that, you know, people can have a JAK2 mutation decades before they have an MPN, right? So again, it's kind of coming back to that question earlier. What are the collaborating things that have happened that cause that patient to go from just having a mutation to having an MPN? I don't think we know that, but we certainly know that this is a disease of stem cells. And, you know, stem cells last decades upon decades in the bone marrow. So I think, you know, that is probably the source of the disease, but there have to be other things that are occurring that are allowing that to progress. And I don't think we understand that completely yet at all, actually.
Would you say the larger percentage of patients that you see on a regular basis are staying the same? Is there an age, you know, if they're in if it's a certain cohort of patients that are 60 to 70, you see more issues, more symptoms, more, you know, can you kind of speak to that?
I think it's highly variable, and it's to me, it's never followed one pattern, right? Because I've seen young patients who really are highly symptomatic and need treatment, and then I have certainly older patients who have the disease and they don't really need anything. They're doing fine. Why is that? I don't know. I've always been puzzled by that, but I don't know the real clear pattern.
So you both, you and Kapila and Rick, jump in at any time. You explained, you know, pretty much the program or the project at the Research Foundation. What do you need from the MPN community? I mean, we have lots of people that we can talk to here and going forward. And we will continue this conversation from our perspective with you and help you as much as we can. Kapila, do you want to speak to that, or Rick?
Yeah. Well, go ahead, Rick. You start, and then I'll finish up. Yeah.
So a lot of the discussion today, great questions. A lot of it has really, the answers have often ended with, you know, we just don't know enough yet. And in many respects, to get those answers, we need large numbers of patients and their information. So it lies within the data that's being generated throughout the world, for that matter. But, you know, our initial approach is to focus in on the United States. And I don't want us to get ahead of where we are in the process of developing this large observational database. But at the same time, you know, we're committed toward this because we know it's needed. So regarding the patient community, you know, we're going to be reaching out to patients to participate, to participate personally in terms of what they would want to contribute for their information, but also to consent to have their electronic medical records be captured, to capture the information that exists within there, that information about their blood counts, about their histopathology, about their genomics to whatever level that information may exist, and any other information that may be from a research perspective that can be valuable, because captured within all of that information and with large enough numbers now really gives you the ability to diagram out the natural history and perhaps get closer to personalized predictions that Dr. Rampal truly needs in order to be able to talk one-on-one with patients about this. But as I said, I think from our end, the goal really is to provide the community with the endpoints, especially the clinical trial endpoints that are needed to now look at those interventions that can now start to halt progression and be valuable beyond progression. I mean, this thing will go well beyond that.
So it would seem, based on that, it would seem that the entire MPN community of physicians would be very eager to participate as well and to bring their people together and have discussions about that.
Yeah.
Kapila, did you?
Yeah, I was going to add to Rick's comments here. I think the way we think of it is almost like a three-legged stool, right? We've got our patient community, which, as Rick very well articulated, we need the engagement and the opportunity to learn from our patients and perhaps access, get the consent to some of the medical records, but really just learn what their experience is about. So that patient engagement is going to be a big part of it. The second piece is you're talking about, Anne, is the clinical community, the physicians and the research community and contributing their thought leadership. Help us figure out what are the right studies and where can we find some of these patients with the unique cases to aggregate the data. And then the third piece of it is really the pharma community and helping not only support the initiative, but help us, again, with some thought leadership to understand what is it collectively that this three-legged stool, if you will, can take to the regulatory authorities with a body of evidence to say, okay, here's what we really need to test in clinic, and ultimately get new therapies approved. They're meaningful and not just incremental and suppressing some symptoms here or some symptoms there, but really meaningful therapies. And so I think of that, like I said, that three-legged stool of engagement from the overall community to help us take some evidence to the regulatory authorities.
So this question just came in. So let's say you stop the progression. Let's say I have MF and I'm symptomatic, but I'm on a treatment, Basrami, something, and you are able to stop the progression of my disease, but do I still stay in that space of still needing treatment and still, Raajit?
Well, that's a tough one. Well, I guess let's extrapolate from other things, right?
Maybe CML, Raajit. Maybe
Right.
that's
CML is a good thought, but
Yeah.
even with interferon, right?
yeah, interferon. Yep.
Interferon, we know that there is now this great data that you can actually stop interferon in some proportion of patients, and they can have a prolonged period of no disease. And the same is true, as Rick's pointing out, in CML, right? In some patients, you can stop their medication and they won't have recurrence of their disease. About 55% of patients. So it's certainly not everybody. So I think the answer and the possibility is yes. Could people be off treatment at some point? Yeah, possibly.
So we just got a great question, and I would say yes to this, but I'll wait for your reply. Are doctors participating in the observational database, or should we ask our hematologist to do so?
So again, I think, as Kapila said, so we communicate both with the research community clearly. In fact, that's where all of this started, when we gathered the community at a couple of summits to talk about the right path forward and to get the research community worldwide gathered around this particular issue. And clearly they're going to remain engaged, and we want them to inform their patients or have their patients inform them. Either way, because the greater the population and the more data, the more powerful this really becomes. So that I would say, any way we can make it happen, man, is the way we.
Right.
And I would say specifically in the short run, if you want to sign up on our website and indicate that you have an interest in this, we'll gladly, reach out to you and indicate your interest. So we would like to hear that. And probably it'll be later this year that we start to go out to the clinical community as well for broader outreach. So make sure your physician is aware and knows as we start to build our awareness campaign around it, probably mid-year. So, but I think the first step is to visit our website, let us know that it's something you're interested in, and we'll be happy to connect with you.
Good. I got a great question here, and thank you. And we will promote this as well as your partner and colleagues. But any recommendations? This is kind of our last question, and then Raajit and Kapila, whoever would like to put closure on this 1 hour program. So should a person start to look into getting a genetic profile now, if they're interested? And is there, and does insurance, are there issues with insurance covering that for this research project and possibly others? We really try to help people with their insurance coverage for certain things. We have not done it for genome sequencing, but Raajit, have you any experience in this?
Yeah, this is a complicated question, and because insurance is so fragmented in the United States, I know that I have colleagues in other states where they struggle to get these things covered. And in other places it's not a problem. Here we don't have an issue with MSK because we do everything in house. So if it's not approved, we think we usually waive the cost. But with a commercial insurer with a commercial test, it's a little bit different. I think right now it would be incredibly hard for an insurer to argue that getting a genetic profile is not standard of care. Okay, because it is in national guidelines, and so I think if we think about this on a practical level, is it important for patients to get a genomic profile? I think the answer is absolutely yes, and there's a wealth of data. And it's my hope that insurance companies would realize that, or not put up a fight against patients getting what I think is absolutely standard of care testing.
The other thing I would just quickly add to that is if we do, part of the beauty of putting a larger database or a cohort together like this is being able to uncover where there might be pockets, whether they're in community practices or certain areas of the country or certain carriers that are not covering because we're not able to capture that genomic data. If we can collect that evidence again and elevate and create that awareness, we can actually start to influence that hey, this really needs to start happening, because as Raajit said, it is part of standard of care. And if there's a pocket where it's missing, we can start to create awareness there.
The other question would be, if I'm a patient and I say, I want to be involved in this study, is there, sometimes, when you're in a clinical trial, you might have other costs, but the drug is not, you don't have to pay for the drug, so do you see possibly in the future, as this goes on, that if a patient contacts you and says, I really want to be in this study, I don't have the funds or the resources, because again, we live in the United States. There are a lot of people that are uninsured or underinsured, and many of whom are our patients, but they want to be involved.
Yeah.
Do you see a possibility of helping, like in a clinical setting,
Sure.
whoever, this person should get their genome,
Right.
Yeah.
I think it comes to building that body of evidence and figuring out, how much, where are those pockets and gaps, and where really is that standard not being applied?
Okay.
And then, sure, I think if there is that still a gap and we're not able to influence it through the systematic changes, then, assuming there's support and funding available to do that, we could look, it's a possibility.
Yeah. Well, we have 2 minutes left, and so I am going to turn those 2 minutes over to Raajit and Kapila for the moment. And Rick,
Go ahead,
if
Raajit.
anything else to add, and we can close this conversation, but we are going to open it up again in the near future, because we have a ton of extra questions here, and we knew we would, and we want to continue this conversation with all of you, because it is so important, so very, very, very important. I've been waiting for this day, and so as our patients have, and so we will continue to do this.
Yeah.
But Raajit, do you have any
Go ahead,
closing
Raajit.
comments?
I think that if you live or work in the oncology world or field, you have to be an idealist, otherwise you wouldn't get out of bed in the morning. And what we're doing is about building a more ideal state, right? We all want to live in a world where, you know, I can say, look, you have this diagnosis, we're going to do this, or we're not going to do this, and the likelihood is you're going to be fine. That's the simple ideal statement. Maybe I'm being naive, but I'm optimistic. And that's really what, to me, fundamentally, forgetting about all the details, this boils down to. That's what we're trying to do.
I love that.
And I'll just close it by saying thank you, Anne. Thank you so much for the opportunity, and thank you to the patients out there who have asked us very thoughtful questions. Please keep them coming to us. If you want to come to our website and enter them or email us with them, we can get them, you know, to Dr. Rampal as well. But more importantly, we want to engage you in this important conversation. So thank you.
And we will continue to do so. You know, we've got a great partnership and very synergistic here. And so, you know, we will continue to have these conversations. And Rick, do you have anything to add?
No, just thank you, Ann, and thanks everyone for participating. I always enjoy listening to Raajit provide answers to all these questions. So, and just so important to start raising awareness, even at this early stage. This is going to be a long-term commitment by the foundation. Yep.
Yes, absolutely, and fantastic. And Raajit, I love your optimism, and I'm right with you.
Yes. Thank you.
Take care, everyone.
Thank you, Anne.
Take care.
Thank you.
All right.